So once again, thank you for joining today's Health Education and Learning Program webinar on value-based care is here. So let's learn about it. By attending this webinar, participants will understand the origins of and rationale for value-based care and value-based payment, appreciate the importance of robust primary care to advance value-based care, and consider next steps to enhance value-based care capacity in rural healthcare organizations. The National Rural Health Resource Center, or the Center for short, is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. As the nation's leading technical assistance and knowledge center in rural health, the center focuses on 5 core areas. Those exist to be the transition to value and population health, collaboration and partnership, performance improvement, health information technology, as well as workforce. The center is committed to building a culture where difference is valued. We create an environment that reflects the communities that we live and serve, a place where everyone feels accepted and empowered to be their full, authentic selves, and where everyone belongs. We understand the impact of and seek to defeat racism and discrimination in ourselves and our workplace in the world. And this guides how we cultivate leaders, build our programs and resources, as well as deliver our technical assistance. We're an organization that honors, celebrates, and respects all dimensions of diversity, and these principles are central to our mission and to our impact. And I encourage you to click that link to read more about our DEI statement, as well as see a video of our staff as we talk further into this topic. Thanks again for joining today's presentation, and I would like to welcome Dr. MacKinney. Clint MacKinney has worked in healthcare for nearly 40 years, including 14 as a rural family physician practicing the full scope of family medicine. Most recently, Dr. MacKinney worked for 15 years as an ED physician in rural Minnesota, and he is now the clinical associate professor in the Department of Health Management and Policy at the University of Iowa. Dr. MacKinney worked for 8 years as a National Rural Health Care Consultant and has provided healthcare organization performance improvements in approximately 75 rural communities. Dr. MacKinney served as a clinical consultant to the CMMI Pennsylvania Rural Health Model and continues to study rural ACOs. He's also has publication themes and national presentations, including healthcare value, physician and administration relationships, and rural hospital payments and rural health policy. Thank you for joining us today, Dr. MacKinney, and I will now turn it over to you.
Okay, thank you. Thank you very much. That was kind of long, but thank you for suffering through that introduction. Let's see. First off, Kiona, does that look okay?
Looks wonderful. Thank you.
Okay, good deal. Second, I got to do 2 shout outs if you guys will let me. Ray Hino, you were one of my early supporters, probably 10 or 12 years ago after seeing me present. Thank you very, very much for suffering through me one more time. And then also, I think it was Sharon from Bryan Health Connect. I'm working really closely with John Finley. So some really high quality folks over there in Nebraska. Thank all for joining as well. So with that, one more housekeeping. I didn't know there was going to be a quiz. So in any event, is that when we get all done, let's all kind of say, do we know did I convey what we were supposed to? And if I didn't, I'll repeat it, because everybody should get 100% on their quizzes. So I will try to do that to the best of my knowledge. Let me start first. Well, let's see, I will start first in just a second. Well, maybe not. Okay, there we go. Just a little slow. And back up. So I do need to tell you a little bit about the team that is working on this project. So I come to you as a member of the Rural Health Value team. We're located at Stratus Health, the QIO in Minnesota, in Bloomington, just outside of Minneapolis, and then also where I am in University of Iowa, down in Iowa City. I actually live in Wisconsin, and I'm really at a different meeting in Phoenix, so kind of all over the place. This is a very cosmopolitan webinar that we're doing right now. But the Rural Health Value team has been funded by F4HP for the past 10 years, and we're re-upping right now an application process, and it's been just a fascinating book of work that we've been doing. And I've listed some of our some of our charges and some of our resources there. If this concept of value in healthcare that we'll talk about over the next 45 minutes or so kind of tends to light your fire like it does for me, we have lots of resources, lots of places to learn a little bit more. And you know what? You can always email me. I'm as close as an email. And if you have questions or looking for different sources of information, please email me. I'd always be happy to have a conversation with you by email. I'd like to start with a hypothetical with you, if I could. Let's just assume for a second that you're sitting down and sharing a glass of wine or sharing a beer with a close friend or a close family member, and you ask them kind of a fairly what we think would be a basic question. You know, what do you expect of the healthcare system? What do you expect when you go see your doctor or you go to your hospital? What do you expect from that? And I think if somebody's being pretty thoughtful, what they'll probably say is, well, if I'm sick, I expect to be made better. I mean, be made well. That would be number one. And number two, they might say, you know, I've heard about medical errors in the newspaper, so I want to make sure that I'm safe. You know, I don't want you to hurt me when I'm in your hands. Number three, I might say in this conversation, you know, when I think back to the time that I was sick, I was frightened. I was confused. I was worried for my family as well as myself. So during that time of discomfort, of unease, I want to be treated compassionately and with respect and sensitivity. So I think I'd want that. Oh, and then I might say, by the way, I just got my tax bill, or I just got my insurance premium bill, and I'm paying a lot of money for healthcare in this country right now. So I hear about, you know, wasteful spending in healthcare, and I don't want you to waste my hard-earned dollars. So I think they're going to say that. That's what I think. I think they're not going to say something like, well, I really expect it to be seen as fast as I can, as fast as the doctor can see me. Or I expect when I go to the hospital that it'll be completely full because that's how they make the most money. I don't think you're going to hear those kind of words. So I think you're going to hear, I want to be treated with high quality. I want to be treated with compassion and respect, and I don't want you to waste my money. So I think that's what most reasonable Americans would say if they're asked this question, have some time to think about it. So what am I talking about? What am I talking about? Now, I won't ask you to answer, but what I'm talking about is the triple aim. Now, I got to give you a little bit of background on this. In 2006, I was asked to speak in Marquette, Michigan, in the UP of Michigan, about why is the government getting into our healthcare? You know, and this was right after the Medicare Modernization Act in 2003. So people are going, you know, why is the government messing with my healthcare? You know, and I came up with the idea that the reason why the government and others are messing in our healthcare is because we're not delivering the value of healthcare that we all know we're capable of. So I put together this kind of little simple equation, and I've kind of modified it a little bit over the years, that when healthcare value is really the triple aim, and it is quality plus the patient experience divided by cost. Now, I'm not a mathematician, but I can add and divide, and this really, really appealed to me. It seemed to make sense. Now, as I say that, value means different things to different people. Heck, value can be a verb and it can be a noun. In this case, I'm really talking about it as a noun. But if we could just put aside the nuances for just a second, and they're important, but let's put them aside for a second. This is a relatively easy way to think about what we can be doing better in the healthcare system. So that was in 2006. And then in 2008, Don Berwick came along, all bow, the guy's amazing. And he wrote an article, I think it was in JAMA, but I'm not positive about that. It may have been New England Journal of Medicine, and where he talks about the triple aim. And of course, this is the triple aim. This value equation is the triple aim. And I really felt validated, you know, after that here I had spoken about the same issue 2 years prior, and now it's really taken off. And I got to admit, I come back to it again and again and again as I think about how do we need to adjust the system. And as I'll talk about more in a little bit, how do we adjust payment such that we start to reward value in healthcare, not volume in healthcare. So you might ask, so you're talking about this volume to value kind of transition or transformation, how do we get from where we are now to something different? Well, right now, especially around payment, we're primarily in a fee-for-service environment. And what that means is doctors and hospitals get paid for each unit of service they produce or deliver. It's like a widget coming out of a factory. And that's kind of what fee-for-service is. Now, it's not all bad. It rewards industriousness. I mean, the harder you work, the more you get paid. It also kind of rewards efficiency as well, too. But I'm going to argue that it contributes to the high cost of care, because what fee-for-service means is that I'm going to use myself as a physician. I get paid more the more I do to you, whether it helps, hurts, or does nothing for you. Well, I think most rational people would say that doesn't make sense. But that's exactly the way the system works. And for those of you who are working in a critical access hospital, lest you think that cost-based reimbursement is not fee-for-service, let me disabuse you of that. Cost-based reimbursement is simply fee-for-service, a wolf in the fee-for-service sheep's clothing. And what it actually is fee-for-service because you do better as a critical access hospital if your beds are full. We won't talk about the accounting, but the accounting such is if you fill your beds, you're going to do financially better as a critical access hospital. So, and then I'll lastly add to this that I don't think this helps professional satisfaction, even though we have some control over our destiny. How many times did you hear, doctors complain, they're making me, the man is making me see 30 patients a day or whatever it is. So I'm not convinced that this is really leading to professional satisfaction. So let's think about a different future with value-based care. Now, this is going to require something different than what we have right now. First, it's going to require team-based care, because that's how we're going to improve quality and we're going to improve efficiency both. And the relatively early experience, especially around accountable care organizations, which I'm going to talk about in a little bit, so you have a sense of what those are, does appear to increase quality. Reducing healthcare costs, there's some early evidence that it reduces it some, but not as much as everybody would really like. But we're on the right path towards some cost control through value-based care. And I think it improves professional satisfaction. I really do. The professional satisfaction is now the quadruple aim. Maybe you've heard of that. It's kind of an add-on to the triple aim, is how do we ensure that our clinical and supportive workforce is professionally satisfied in this very noble work. Now, value-based care is this way. So when people want to kind of know what is value-based care, value-based care is care that prioritizes high quality, person-centered, and efficient care. What it does not prioritize is volume of services. So when we talk about why are we making this change, why are some, like myself, recommending this transition from volume to value, is because volume-based care, fee-for-service, doesn't recognize or reward the triple aim. But value-based care starts to. It tends to reward financially either high quality, person-centeredness, and or efficiency, or all three combined. But it's not fee-for-service. And when you talk to experts in value-based care, when you ask them, where do we go for models of doing this properly? They tell you, we look right at primary care practices, advanced primary care practice, robust primary care practices, those like you see, and you've heard these words, patient-centered medical home, or we tend to kind of prefer to use person-centered health homes. But the idea of team-based care, proactive care, data-driven care, culturally sensitive and respectful care. That's where we look to examples of how can we increasingly deliver value-based care to our patients and to our communities. But we have a problem. We have a problem with this. And here's the problem. So you guys may recognize that this is Winston Churchill. And Winston Churchill we think he said, he said this. You can always count on Americans to do the right thing after they've tried everything else. So let's do a quick rundown of what we've tried of kind of everything else. We've tried fee for service. That's what I was just describing. We've tried full capitation, where we just tell a doctor, you take care of this number of patients, and you get one lump sum at the beginning of the year and go out and do good work. Well, what they really found is there's sometimes skimping on work. In fact, there's a very interesting study of cataract surgeries between doctors or ophthalmologists that were on a capitated program, meaning they just got one lump sum at the beginning of the year to take care of a panel of patients, versus those that got paid on a fee-for-service basis. And guess what? The number of cataracts done in a time period were about 50% less than in the capitated group rather than in the fee-for-service. Now, that doesn't tell us which one of those doctors is doing it right. It doesn't tell us, is the lower number right or the higher number right? It just tells me we don't know the right answer yet, and I'm not convinced that full capitation is really the way to go. I'm like fee-for-service. I'm not convinced that is. What else? We just rely on the market. That's what government wants to sometimes do. They let that isn't working out so well in rural America. So we have all of these very complex add-ons to the current system, like cost-based reimbursement for critical access hospitals, sole community hospitals, low Medicare volume hospitals, blah, blah, Medicare dependent hospitals. We have all these kind of add-ons that are trying to adjust because the market isn't doing it well. So I'm not convinced that's it. Single payer. Well, there's a lot of talk about single payer, especially of Medicare for all. Well, the devil is in the details, of course. And even though I think single payer would add some administrative efficiencies, I'm not so sure we're really getting at this concept of how do we reward doctors and hospitals, clinics, and teams to provide value-based care, quality, patient experience, lower cost, as opposed to fee-for-service. So I can say, what about paying for healthcare value? Well, one of the probably truths just about everywhere is follow the money. So form follows finance. How we deliver care depends on how care is paid for, how we get paid for care. Right now, we're paid on widgets. So what's our natural reaction to doing this? Isn't malicious. This is just what happens. We tend to produce more widgets. So, and hence, that's one of the great contributors to the high cost of healthcare in the United States. Now, it's not the only one, certainly, but I think it is one. But healthcare reform, in the form of the Accountable Care program in CMS, many of the models from CMMI, is changing both payment and healthcare delivery. So it's payment, it's supplying the fuel for this volume to value transition. It's not automatically happening, it's on its own. I wish it would, and again, I'm not implying that all doctors, hospitals, nurses are malicious, money-grubbing cutthroats. But I think if we have the incentive around finance helping us move in the right direction, that movement will be faster. So I've been kind of talking a bit about payment, and I always wonder if when I give a talk like this, people are going, well, why is this doctor talking about payment? Well, I think the reason why is I've learned, and I hope it's not being a curmudgeon, that incentives matter. I'm interested in behavioral economics, and I think if you would ask an economist what is the basis of all economics, he or she might say incentives matter. Now, understandably and very importantly, not all incentives are finance, not all. But if you think of this from a policy perspective, what levers do we have at a state level or a government level to affect behaviors? Well, we actually have payment, that's one, and we have regulations. Those are kind of the primary levers that we have, and payment's pretty powerful. So I'm arguing, let's start getting the payment behind what we all would like and expect from the healthcare system. So value-based payment for one or more parts of the triple aim, which again is better patient care, improved community health, and smarter spending. It's not payment for a service. And to receive this value-based payment, to receive it, we must deliver value-based care. We must deliver high quality. We must deliver patient safety. We must deliver a positive, respectful, compassionate patient experience. And we must do so in a way that uses precious resources wisely. So I was kind of saying that this is a little bit odd for me to be kind of talking about payment, especially as my entire career as a rural family doc. But this idea of money as a medium of exchange is really important. And as I said, incentives drive behavior, but not all incentives are financial. But I'm arguing, let's incentivize the triple aim. Let's make it easy. Let's make it profitable to actually deliver on the right thing, which I think is the triple aim. Now, when I talk about payment, different kind of value-based payment, I kind of tend to think of this in a kind of a continuum. And you can see on the left side of your screen a volume-based payment continuum, which is fee for service. And then all the way to the right side of the screen, total cost of care. And there's things in the middle. There's things in the middle between getting to fee for service and providing a lump sum to provide quality of care for an entire population over a variety of diseases and conditions. But so right now, we're kind of moving off of fee for service and dabbling in the pay for performance and value-based purchasing space and the shared savings space. And here's some examples of that. These are value-based payment examples. So one is, the shared savings and losses type of idea. And I'm going to talk about this a little bit more so you have a good sense of what this idea is. And here's an example, is the Medicare Shared Savings Program, or ACO program. Oh, and by the way, around nomenclature, when you see the words program, what that means is this is something that's ensconced in law. It's not a demonstration. It's not a model. It's not temporary. It's in law until Congress changes it. On the other hand, a different example, though, is a global hospital budget, which is the Pennsylvania Rural Health Model. You hear that word? It's a model. This is a demonstration that's going on in Pennsylvania right now. And I'll talk about that a little bit more. There's partial capitation, the primary care first model, and kind of the big kahuna, which is the total cost of care. And this is the Maryland total cost of care model. So anyway, these different examples are kind of in place right now, and you may have heard about them. And I'm going to talk a little bit more about them in just a little bit. Here's some of it by the numbers, lest you think that this is just kind of a passing fad. Well, right now there's nearly 1,000 accountable care organizations in the country, which covers 10% of the population, and almost 500 of those are Medicare ACOs serving greater than 11 million beneficiaries, Medicare beneficiaries. We have lots of models going on right now, from the Center for Medicare and Medicaid Innovation, rural hospital budgets like in Pennsylvania, primary care capitation are going on right now. And it's not just Medicare. It's easiest for us to track on what's happening in Medicare, but many state Medicaid programs are working on developing how to reward value-based care rather than just volumes. Commercial insurers are doing it well. Blue Cross Blue Shield has their Blue Alliance program, which is a value-based program that's, I guess, administered a little bit differently throughout the country, different blues in the country. But anyway, it's not just the government that's moving in on this. And I think some people might even argue that the commercial market may be moving faster than the government is right now. The next thing is, this was interesting, late 2022 or fall 2022, CMMI, Center for Medicare and Medicaid Innovation, did a strategy refresh. So they kind of redid what their strategic thinking for their organization would be. And they're saying this, they're saying that all providers, that means hospitals, physicians, nurse practitioners, PAs, dentists, blah, 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 should be accountable by 2030. So when they're talking about accountable, that means being paid differentially based on quality of care, patient experience, or cost of care. That's pretty big. So I think it behooves us to say the status quo isn't going to be the status quo all the time. Things are going to change, and the status quo is not risk-free. That's key. So people who maybe believe that this is a passing fad and I'll either retire before it gets me or I'll just ignore it, I think do so at their own peril. So that's why I'm glad all of you are on this webinar, so we can at least learn some basics about what's going on in the value-based care and payment space. So let's do some examples here. I want to use the example of an accountable care organization, and I want to use an example of a rural hospital global budget to kind of talk about two relatively prominent examples of value-based payment that are going on in the country right now. Accountable care organizations is by far the broadest, most widespread value-based payment system in the United States right now. And as I mentioned, Medicare is not dabbling. Medicare is in this space. They call it the Medicare Shared Savings Program, or MSSP. Commercial insurers are in this space, like Blue Cross Blue Shield with their Blue Alliance, and Medicaid is getting into this space as well too. So here's what an accountable care organization is. It's groups of providers, usually physicians and or hospitals, that receive financial rewards for improving the quality of care for a group of patients while reducing the cost of care for that same patients. That's what it is. So here's how it kind of works. Let's just say that we're going to use the example of just one patient. Obviously, a physician or a hospital or an ACO will have lots of patients, but let's just use one patient. And CMS calculates that this particular patient is going to cost the government, cost Medicare, $10,000. That's what they believe. That's our predetermined budget of $10,000 for this one patient. But through care coordination, through helping people come to the clinic rather than going to the emergency room, blah, 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 we actually are able to not charge the government that full $10,000. Instead, the government looks back and says, wow, for that particular patient, we were only charged as Medicare $9,500. Well, that leaves a $500 delta or differential, doesn't it? So what Medicare then says is, okay, the government saved $500 on this patient last year. Therefore, we're going to share 50% of that money back with you, the accountable care organization. We're going to write you a check for 50% or $250. We're going to write you a check for that patient. Not so fast now. Wait a minute. There's quality requirements in this as well too. You can't simply just skimp on care. You cannot do that. It's morally unconscionable. But also they won't let you do that. So we do have quality scores, and your 50% payment can be deducted because of lower quality scores. Now, the cool thing about this is, as we and others have studied ACOs over the years, their quality goes up. So they're really changing processes to have better quality of care. Now, we can argue whether they're measuring the right kind of quality. That will always be a fair argument. But for what what the government has determined is high quality care, ACOs are improving on it. So when I talk about that there's evidence that value-based care and payment programs tend to improve the quality of care, I've got the data to show that. So I think this is really important. It's what lights my fire about this. We provide incentives to do the right thing, and son of a gun, people do the right things. So this still needs work. As I said, we could argue appropriately about whether the right quality measures are being evaluated and thus paid for. But the idea is we're still starting here, and we're moving in this direction. Now, interestingly, I talk about value-based payment, but actually, accountable care organizations are still fee-for-service animals. They're still, the entire time that they're operating, they're getting paid by widgets. The only difference is the cost of the widgets are all added up at the end of the year. And if it's less than the predicted amount, you get to share in some of that savings, but it's still fee for service. So it's a value-based component to a fee for service platform. Now, again, you think that this isn't really going on. Well, actually, it really is. There's quite a bit of activity around the country, even in rural areas, where we see accountable care organizations participating. And to be able to receive the cost savings, remember, this is a share. So think of it as Medicare is sharing some of their cost savings back to you, but it requires first outpatient care performance. Those of you who are based in a hospital, guess what? The performance measures are all outpatient based. They're outpatient. It requires primary care visit attribution. So patients aren't assigned to an ACO through their hospital, they're assigned through their primary care provider. So again, primary care becomes essential here because we want to have patients in our ACO. We want that, and we have to do that through our primary care providers. It requires population health management. We need to know at the beginning of the day, preferably, which patients need their preventive health interventions, which patients need their chronic disease management. We need to be thinking about that before the patient does, and then provide that to them because, one, it's good quality care, and number two, it's going to help us receive value-based payment, that shared savings at the end of the year. It requires financial risk management. How do we evaluate the cost of, say, a population health module to our EHR compared to what we think we might make in shared savings? Those are really tough. I'm not the financial guy, but this sounds like we need actuaries, not accountants, in this kind of financial risk management. And then lastly, I'm going to hit on it again and again and again, if I can, please. And that's, we need robust primary care. We need primary care that thinks about population health, thinks about proactively serving their patients, uses data to make wise decisions and improve the quality of care, is respectful and compassionate, understands what access means. That's what good patient-centered medical homes, better word, person-centered health homes, means. And we need to have that robust primary care to be effective in our delivery of value-based care, which in turn allows us to receive value-based payment. I'm working with the guy who was the ex-CEO at the hospital in Manitowoc, Wisconsin. And he joined the Bellin ACO. Bellin is a large healthcare organization based in Green Bay and had a really, really good ACO. And Brett managed a tweener hospital, so maybe bigger than a lot of the CAHs, but still a tweener hospital. And he said that ACO put $2 million to my bottom line. $2 million. Now, he didn't just get a check. They earned that $2 million. They earned it through high quality and patient satisfaction. They earned it. And then what did Brett do? He turned right around and turned that $2 million into salary increases for his staff. So that's how that money got used, is to salary increases. So this idea of shared savings and accountable care organizations is still fee for service, but it's still moving in the direction of value-based payments, value-based payment layered on top of a fee for service platform. Now let me switch to a global budget. So let's just say you're a hospital CEO in rural Pennsylvania, because this is where this particular model is taking place. And you're a pretty smart woman. You know how to look at data, and you used to be the CFO, and you've developed a nice little Excel chart here that shows your revenue trend from 2019 to 2022. We'll forget about COVID for just a second. But it's going down this way. So you're trending it to continue to go down because you don't see any significant changes in your ability to control costs, and you don't see any significant increases in your prices, and you don't see any significant increase in your population. So you're seeing a revenue trend that looks like this red line going down. You're going, oh man, what am I going to do? Am I going to have to sell the hospital? Are we going to go bankrupt in 5 years? What's it mean? And along comes someone who says, how about we just give you a global budget based on your revenue back in 2019? And that's where the green line is. So you can see for small rural hospitals that are seeing themselves financially headed towards ruin, global budget can be really, really important, really important. Now, obviously, if that red trend line is going the opposite way. If it's going up, you don't want to be stuck with a global budget when your potential revenue is going up. But a lot of hospitals in Pennsylvania found that this was really helpful. And interestingly, in Pennsylvania, the global budget was implemented right before COVID, 2 years before COVID. That was when it was implemented. Oh my goodness, did it help out some of these rural hospitals where volumes just tanked? So they were able to maintain their cash flow because of a global budget, even though the public health experience actually kind of destroyed their volumes, destroyed their ability to make money in fee for service, and the global budget preserved it. Now, I wish I could tell you it's as easy as this little chart makes it seem. There's lots of nuance, lots of challenges in implementing this global budget. One of which is actually the insurance companies. They don't really like paying for things that are beyond the cost of production. So if we think of healthcare as a cost of producing healthcare, they don't really want to pay for more than what they're getting. So in any event, the idea behind the global budget is any excesses between what you spend and what you make in the global budget is supposed to be plowed back into community health, but insurance companies are a little bit reluctant to do that. So what we really found, I think, in Pennsylvania is that more than the finances, and even though the finances is what drove the hospitals to participate, what they really found was if we could be somewhat unshackled by our fee-for-service revenue, if we can just stop having to think about that quite so hard and strategically plan for that quite so much, maybe we can start thinking about things that we would like to think about but haven't been able to in the past. Like, how do we serve our community? How do we help people stay out of the emergency room if they don't need to be there? How do we improve access to primary care? How do we help, and this is the managerial opportunity, how do we help our staff, our medical staff, our clinical staff, and even administrative staff start to think in ways beyond volume into thinking about how do we make people better? How do we improve the health of our community? Wouldn't that be cool? Wouldn't that be a really liberating opportunity? Wouldn't it be an opportunity to test out some new ideas about how to deliver care? And wouldn't it be a cool way to get paid for actually providing community health care, which, by the way, right now in critical hospitals is not an allowed cost? So how can we do that? And I highlighted in the blue here, allows focus on mission. You know what? I bet if I pull the mission statements out of about every rural hospital in the country, it's going to be some tagline that's something like, we provide high quality care to the community that we serve and in which we live. It's okay. There's nothing wrong with that at all. But the challenge is what happens if that's not congruent with being able to remain profitable and to continue as the accountants would say, a going concern? How do you do that? Well, if a global budget allows us to start thinking about mission, maybe it allows a board to start thinking about their duty as a not-for-profit organization, and then helping them ensure financial success while doing the right thing. It makes balancing these demands between financial success and doing what's right for patients in the community that much easier. Really cool. And as part of this project, all the hospitals were required to put together what is called a transformation plan. And it was, we promise to do these things to, 1, reduce avoidable utilization. 2, serve our community. Or 3, improve operational efficiency. We promise to do, and they chose them, these 3 projects as part of the quid pro quo for receiving the balanced budget. Pretty cool, pretty cool. So thinking to the future. What does this all portend? Kind of looking to the future a little bit. Well, increasingly, we're going to find that fee-for-service, the widget production, is going to be less and less important. Not unimportant, not gone, but a gradual devaluation of fee-for-service with replacement with this value-based payment. And that's payment for delivering better care, better patient safety, improved community health, and smarter spending. And of course, what I'm saying here is this Value-based payment requires and then rewards strong primary care participation, which then turns around and delivers value-based care. I also think it portends an opportunity to better deliver your healthcare mission as an organization. Here's some ideas of folks who can help you spread innovation and participate in innovation. You see the National Rural Healthcare Resource Center right there up in center, the organization I work with, Rural Health Value. And the cool thing about all these organizations, we all work very closely together. We have, among most of these organizations, we have a quarterly call where we talk about how we're all advancing value in this space. So all these are great organizations and really committed people to help you in this project. And I'm going to end with this, and I try to do this because I think it's so important to stop for a moment and ask yourself, why are we even talking about this? Why are we talking about this? And the title of the slide is Healthy Critical Access Hospitals, Healthy Rural Health Clinics, but mostly healthy rural people and places. And we want, all of us want our rural communities to a place where our kids can learn and grow and experience new things. We want a place where our workers are safe and productive. And we certainly want a space and a place for the seniors in our groups to age gracefully and with compassion and also with safety. So I'll end there. I will be happy to take questions, but Kiona, I will stop sharing and turn it back over to you.
Thank you. And thank you for that great presentation, Dr. MacKinney. We will open it up for questions. So if anybody has any questions or comments, please feel free to unmute your line or type them in the chat box. I do want to address just one question that was in the chat earlier. The presentation and the recording will be linked within the playback within 5 business days. So you will receive notice of that. Otherwise, I think I saw somebody unmute if you wanted to ask a question.
I would like to. I'll go ahead and jump in. This is Rhonda Barkas with the center. Thank you so much, Dr. MacKinney. That was so informative. And
Thank you.
This is such a complex topic, I think. So I appreciate you making it very manageable and understandable. The question I have for you is, the Rural Healthcare Provider Transition Project, the one that supported this webinar. We work with small rural hospitals and rural health clinics to prepare for value-based care. Could you speak a little bit to the role of the clinics? Because I think that's not quite as obvious for folks.
Well, so when I talked about robust primary care, when I talked about patient-centered medical homes or person-centered health homes, I am talking about a rural health clinic too. So most rural health clinics are primary care focused, I believe. That doesn't mean there might not be others. But I just saw, and I think I'm getting my numbers right, I just saw a release from CMS 2023 release, probably 2022 data, that nearly 50% of rural health clinics in the country are now participating in a Medicare shared savings program. I'm going to guess that many of those are participating as with a consolidator. So probably the consolidator, ACO consolidator you all are most familiar with is Signify Health, which was previously Caravan, which was previously National Rural ACO. But anyway, if those numbers are right, 50%, that's really significant. So rural health clinics are participating here, they are, but they will participate best as robust primary care centers. And again, robust may be kind of a little bit of a squishy word, but what I'm talking about with robust, I'm talking about team-based care, data-driven care, population health management, proactive care, and person-family-centered care that's respectful, sensitive, and compassionate. That's what's going to get us, that's what's going to deliver value-based care. And in turn, that is what's going to hopefully get us value-based payment. That's kind of the whole intent.
Thank you.
Mm-hmm.
Are there any questions out there?
I actually have another one, but I didn't want to be greedy. So I was pausing to let somebody else ask, but I'll go ahead and ask.
Sure.
So when you were showing the map of the United States and the percentage of ACO lives in the different states, I was just really curious about why some states are embracing this more than others, and wondered if you have any thoughts, because I live in Georgia and that one didn't show very high.
Yeah, Ron, I really don't have a good answer for that. What we know is that accountable care participation in accountable care organizations seems to be facilitated by prior managed care contracts. That's by one. Seems to be facilitated by a degree of financial stability. So that, and then also there's probably something that's that I don't know if we can really quantify, but it's leadership, interest, and innovation. And I don't quite know how to do that or even assess that. And Terry Hill, all those folks at the center know Terry really well. And Terry and I have talked about this quite a bit, is how do we assess, leadership, interest in being proactive and being creative and being innovative. And I don't think Terry and I have come up with the right answer yet. But Rhonda, I don't have a good answer, but I do know what seems to facilitate participation in ACOs, and that prior history with risk-based contracts seems to make a difference.
Thanks.
Mm-hmm.
We did have one comment in the chat box that I just wanted to share.
Sure.
Sharon said it was a great 101 value-based care presentation.
Thanks.
I will encourage everybody to register for part 2 as we dive a little bit deeper. There is one question in the chat box that is asking, is there a resource where she could see which hospitals participate in an ACO in her specific state?
Oh, yes. And so I got to answer that question 2 ways. Number one, Medicare ACOs, if you go to CMS, and I won't have a link for you right away, but if you go to the CMS website and somehow search on accountable care organizations or shared savings program, there will be a list of the ACOs in the country. Now, the problem is, if you see something like Signify Health, you might not know which individual sites are actually participating. So that's going to be a little bit of a challenge, unless you kind of go into kind of an individual website to be able to do that. So it may have to do a little bit of hunting. Your state office of rural health may know that, or your state hospital association may know, especially obviously for hospitals as opposed to clinics. They may know that. And then also this unfortunately costs money. There's a document put out by Levitt, I think it's called Levitt Brothers Consulting or Levitt Partners, called Porch Insight, and it lists all the ACOs in the country, but unfortunately there's a cost to getting that. So I would start first with doing a look on CMS website, and then might then go, if that didn't provide what you needed, the State Hospital Association or State Office of Rural Health.
Clint, another potential source, Signify or Caravan Health, is far and away the largest of these rural accountable care organizations.
Yep.
On Caravan or Signify's website, they've broken down all the participants by state. So that's another really good source.
You bet. And now do remember, and Terry's exactly right about that. So you're going to get a good number of them if you look at Signify Health, and they do show those. But remember that very first statistic I showed you, there was 900 plus ACOs in the country, 400 plus Medicare ACOs. Signify Health is in the Medicare space. So we're missing the commercial markets, and over more than half of ACOs are commercial. So Blue Cross Blue Shield, for example, or something like that. So anyway, Terry, thanks. You're exactly right. That would be also a really good place to start.
Hi, Dr. MacKinney. It's Ray Hino.
Hey,
Good
Ray.
to see you again. Great
Good to see you.
presentation today. Thank you so much. My question is, for those facilities that are not currently participating in an ACO, what's a good first step to start the process?
Well, first of all, this will be difficult to go alone. And I am not, please underscore this, I am not making a recommendation here. However, Terry already pointed out that Signify Health is the largest consolidator of rural Medicare ACOs in the country. My guess is their promotional team would love to come out and talk with an individual organization. That's what they do. And they have a pretty neat model where you're able to participate in the Medicare ACO without downside risk. So they are confident enough in their processes to get shared savings from Medicare that they will agree to share some of those shared savings with you and not put you at downside risk. Now, obviously, your ability to make money here is less when you assume less risk. But nonetheless, they've kind of got this figured out better than I think many do. Are any of you on the call currently participating with Signify Health or another ACO that could speak to Ray's question and Rhonda's question?
You know, Clint, let me jump in again on this because I'm on the board of the National Rural Accountable Care Organization. And I think one of the things that we have found over the years, that one of the biggest failings is a failure to connect with your primary care physicians. And I know you feel strongly about that, Clint. You're a great spokesperson for that. But in so many cases, the hospital will get fairly far down the road without getting their physicians involved. So one of the things that I'd recommend is have that conversation with your physicians, because their participation and their leadership is going to be really essential here.
Absolutely true. Absolutely. Terry, I think you told the story of, I think you were presenting to a group of medical directors for ACOs, and you asked them how many of you were consulted before joining the ACO. And I think, Terry, you said like 10% of people raise their hands. Well, that's not a good strategy.
No, it's not. And what we also find is that primary care physicians, even though they have this important new role, are very often unaware of what is going on here and their important place in this, because as Clint probably said, the patients in an accountable care organization are assigned to that primary care physician. And in most cases in that regard, it's where they're going to get the majority of their primary care. So they become an essential partner. And as we know, if you can get the physicians on board from a leadership standpoint, it's a lot easier getting the board and the rest of the staff to go along as well.
Boy, isn't that true? If you've got hospital leadership and the medical staff in lockstep for your vision for the future, unstoppable. Not challenges. Yeah. Thanks, Ray.
Sure. I'll just add to that quickly. You've given me an idea. I do happen to know that there's a Caravan ACO participating hospital just an hour south of me. So that would be a good place to start.
Sure. Absolutely. I'm right now at a meeting of North Dakota hospitals, and about 8 of the 36 critical access hospitals in North Dakota are participating with Signify Health, which is previously Caravan. And man, they're singing the praises. They really are. And again, I want to be really careful. And I know Terry's the same way. We're not promoting one or the other. Terry and I have both worked with the founder of that organization quite a bit, but we're not promoting them per se. But I am promoting putting a toe in the water of value-based care and payment. These are skill sets we really need to develop in our hospitals and in our clinics. And this is a relatively low risk financial way to do so. And plus, I've told other organizations, you know what? For a moment, forget about the opportunity for shared savings. What you get, even without the shared savings, is you get data. You get data about where your patients are getting their care and how much that care is costing. So that kind of data to an organization that's appropriately concerned about outmigration is gold. And that doesn't have anything to do with shared savings.
Thank you.
Mhm.
Thank you for those wonderful questions. I think that really just helps drive the conversation a little bit deeper from what we learned in today's presentation.
Yes.
I would encourage everybody, if you have not already, please register for part 2 as we dive just deeper into it as well. If there is no last questions for Dr. McKinney, we will end just a few minutes early.
That's always good. Enjoy your afternoon, everyone, and thank you.
Thank you.
Thank you.